organize them, so you can tell me when to go.
Yeah, we're here now. It's ready.
Go?
Yeah.
Okay. Good evening, ladies and gentlemen. This is the formal chat for the Saturday makeup class. Today is the December the 13th, and I would like to particularly thank everybody for making the effort to be here this evening. I apologize again for the delay in the gathering, but due to technology and Mr. Yame's presence, that is extremely important. However, tonight, what I'll be doing is leading up to Monday's coming Monday's formal class, where we'll be looking at case conceptualization. But I cannot do case conceptualization and looking at some of the disorders unless I go through. I complete the DSM, look at some, for the agenda this evening, I would like to look at the DSM-5 and the concepts and the nature of it. I'll be going through some of the diagnosis, completing that. I'll also be going through the matter of the ICD codes, and I'll be partially going through the mental status examination. I do have tonight we're going to be doing some practice, some small veneers. On Monday the hope is to do one of the major cases, a longer case to give you practice. But just to start, could someone brief me? I know we had talked about, we were on the matter of diagnosis last time, if I recall very vividly. Am I correct? People, am I correct? Hello? Hello?
Yes, Dr. Mack, I was checking my notes.
Okay, yes. Please that I don't go off, I don't veer off.
Yes, you're correct. You're correct, Dr. Mack.
So I'm going to go back to that, and then I will veer to continue with the DSM about the importance of diagnosis. Could someone reorient me? I talked about several, I made several points, and just for me to determine where to start, please. Or to continue?
Good evening, everyone.
Evening. Dr. Mack, you had mentioned about diagnosis is important in the self-report and what the patient says or reports.
Yes.
And then you actually ended off with the DSM-5 and the contextual approach. And
Yes.
that it encompasses the clinical interview, formal assessment, the patient.
Okay, very good. Yes, you're absolutely correct. Very good taking notes. We will now look then at the importance of diagnosis. So I'm going to be making an elaboration on why is diagnosis important in the DSM? Why is it important in the dissemination and understanding and the interpretation of clients' mental phenomena? So there are what I call several important functions of diagnosis, and it is one, the counselor or I would more say psychotherapist, because that's what you're being trained for, is that diagnosis is important in that you need to look at the patient in a holistic way. You need to look at the patient, or the client, I should say, in your context, in a holistic and also a comprehensive way. It is more about importance in gathering information, called collateral diagnosis or collateral information. You are looking at primarily what is known as the presenting complaint. The presenting complaint, or complaints, plural. Now, this presenting complaint is part of what I call the hypothesis process. It's known as the hypothesis process. That is, you are more likely to look at a group of symptoms and you're going to make some informed hypotheses, informed presuppositions, presuppositions, and you're making an inquiry about what you are hearing and what you're seeing. You are hearing it, you are seeing it, and you are interpreting the phenomenon. You are interpreting the patient's symptoms. You are seeing this patient's symptoms, or you are determining what type of phenomena am I seeing, or am I hearing, or am I observing? Now let me underscore that I will want to look at, before I go, I want to make certain that I give you this, that there are a number of what I call diagnostic types that you must be aware of. And tonight when I give you them, I'm going to give you some vignettes to practice. Diagnostic types. One is what is known as the functional type of diagnosis. The functional. That is, it is primarily psychosocial in nature, and there is really no organic or brain-based disturbance. It is where the symptoms are primarily of a physical nature, without a physical nature without a neurological cause. It's called functional. So there are some disorders that will, for example, in some of these the dissociative disorders in the categories or in the DSM, or some of the trauma-related disorders, or the childhood disorders like enuresis or encopresis. Bear in mind that if you look at encopresis or enuresis, apart from the medical terminologies, they can also be seen as functional if the child does not have, there's no physical or medical cause to account for the symptoms. It is known as functional. It is primarily based on the environment. The patient or the client is reacting to a stressor in the environment, and the symptoms are non-organic or non-brain based. Number two, the second type is called psychosis or psychotic type of diagnosis. Psychotic. What is this? It is an impairment in reality testing. That is, the patient's orientation to consciousness, awareness are impaired. The patient's orientation to consciousness and awareness are impaired. In a mental status exam, one of the things when later on we talk about that is that you are in a setting when you ask patients, you are looking for what is known as perceptual disturbances. Perceptual disturbances are, in other words, you ask the question, or you ask yourself, I should say, are there any perceptual disturbances? Is the person aware? Are they having any inner stimuli? Is there any visual or sensory disturbance? Psychotic So psychotic process is that the person is not in touch with reality. So your schizophrenia, your major depression with psychosis, and those disorders that can predispose the patient to a lack of awareness are the psychotic type of disorders. The third, by the way, any questions, ladies and gentlemen? If you want to unmute your mics for questions, please go ahead. Are there any questions? The third is neurosis. Neuroses. Again, this is the opposite of psychosis. This is based really on what is known as an ego-dystonic feature. It is non-psychotic, but it can be very, very distressing and disabling. It is non-psychotic. It is known as ego-dystonic. In other words, there are disturbances within the person which is seen as very disabling and distressing. Again, we refer to internalizing factors. Internalizing factors. The neuroses are sometimes your anxiety disorders, for example. That can be debilitating. For example, panic attacks, social anxiety. These are neuroses, or to an extent, major depression, or to another extent, sexual disorders or sexual dysfunctions, the sexual disorders, or substance abuse. So these are neuroses, neurotic disorders that can be very disabling. That's what the DSM looks at, talks about impairment and disability, that there is impairment in this, in social, impairment in person, of the person, and in occupational function. That constitutes disability in the DSM-5. There is now an emphasis on DSM, which can be measured by an instrument called WODAS, which we'll talk more about. WODAS, WHODAS. It's an instrument to measure disability in the DSM during the interview. Any questions so far, ladies and gentlemen, on this type of diagnosis? Any questions?
None from me, Dr. Ma.
Dr. Ma, could you just quickly, I missed that section you were talking about, disability.
Miss Williams, I'm trying to catch
after you mentioned the examples of neurosis being substance abuse and so on, you said something else after that and I kind of missed it. But anyways, okay.
Sexual disorders?
No, I have all of those. It's okay, Dr. Mack. I'll pick it up.
Oh, okay, all right. You can probably pick that up in the after the fact. Let me. Okay, the organic report. Yes, Mr. Is that somebody speaking? Yes. Hello. Hello. Okay. Thought that maybe I heard a voice in my head. Okay. Organic. The organic diagnosis is very important in the DSM because you're looking at, when you look at some disorders in the DSM, you are thinking about structural changes in brain anatomy. Let me repeat. Structural changes in brain anatomy. They can bring direct impairment, disability, and dysfunction in the individual. For example, schizophrenia is one. Schizophrenia is one such major disorder. So the schizophrenic spectrum disorders in the DSM are organic types. Then you have under that delirium. So you have the cognitive based disorders such as delirium and dementia. Let me repeat, delirium and dementia. Let me make the distinction. Under this organicity, dementia and delirium similar but very different. What's the difference? It is that a delirium is rapid. It's rapid. The person, it is transient, rapid, transient, and the symptoms are quick and sudden. A delirium is a decrease or diminishing awareness of the environment.
You mean dementia, Dr. Mark?
I beg your pardon?
You mean dementia?
No, I meant delirium. I beg your pardon.
So the first one is delirium.
Delirium.
Okay.
Delirium is what I'm talking about. My apologies. Delirium, please. It is rapid. It is sudden. It's quick.
Excuse me, Dr. Ma.
Yes.
Sorry. Which one is delirium? I'm a little confused.
Delirium. I'm giving you the definition right now.
So that one is the rapid, transient, and
Delirium.
symptoms quick and sudden. That's delirium.
Yeah, it's a cognitive impairment of a decrease in consciousness of a person. So the person is not aware of their environment. They're not aware. There's diminished consciousness. So mental status exam is likely to involve the thought processes. Speech may be rambling, thoughts may be chaotic. This kind of illness must be treated in a hospital as the person or the patient can die. Delirium. So in an MSc, mental status exam, the patient is almost what you call there's diminished capacity and awareness. You find delirium in older people. You find delirium in people who have had surgery, or people who have slow metabolism and medication. So there are a lot of things that can cause a delirium, even in a younger person. A person can be drinking. You can have a substance disorder with delirium. So, but this type must be treated in a hospital with medications to bring them back to awareness. The second is dementia, which is more in older people, older persons, 65 and older. No, dementia is a cognitive disorder. Just to underscore that dementia is progressive. It develops over time. Progressive, it develops over time. It involves memory disturbance, whereas dementia, cognitive disturbance, or cognitive awareness rather. This is memory disturbance. Impairment in executive function, in other words, the ability to plan, organize, and initiate things. Impairment in executive function. These are the Alzheimer's type. Alzheimer's type, that's one of the common types of dementia. Then you have Pick's disease, which is a frontal lobe syndrome. Pick's disease. And you have Jacob-Creutzfeldt disease. Have you heard it? Mad cow disease. Have you heard that term before? Unmute your mics.
Mad cow, Dr. Matt, but not the clinical name.
Yes.
Yeah, I've heard about mad cow as well.
But
I've heard about
that's the
mad cow.
name.
Yes,
Yes,
Dr. Mac.
that's the name. All right.
Could you say it again, Dr. Mac, and maybe even spell it, please?
Creutzfeldt's disease, or aka mad cow disease.
How do you spell it, Dr. Mac?
Okay. I hope I'm not misleading you, but Jacob, I think Jacob, CHOB, Creutzfeldt, CREUZFELDT. The last one I would like to add, ladies and gentlemen, is a very important one also, which is not in the book, but I have added it in my experience. It's the neuro, and I believe I've talked about it before, but it's the neuro-psychiatric class type. Why is this important? Because in the DSM, you are going to see a combination of disorders that will have both a brain-based disturbance as well as psychiatric symptoms. Brain-based disturbance as well as psychiatric symptoms. So this is a combination of organic and cognitive impairment, which is superimposed on a psychiatric disorder. It's an organic and cognitive impairment that is superimposed on a psychiatric disorder. They are often difficult to treat because separating the brain disturbance from the psychiatric disorders difficult. Why? Because the structural abnormalities in the brain. So, for example, dementia with depression. It's hard. So most times they target only the depressive symptoms. Parkinson's disease is another one. Parkinson's disease. And the alcohol disorders or the substance disorders, notably Korsakoff's syndrome, which is a disorder of thiamine deficiency. Korsakoff's syndrome. Okay, those are the 5 basic or important diagnostic types that is going to encompass the DSM. Any questions on them so far? Are there any questions, ladies and gentlemen?
None for me, Dr. Mac.
Is that Mr. Barr or Mr. Cato?
Sorry, Dr. Mac.
Okay, Mr. Barr. Good to hear from you, Mr. Barr. Okay, so let's continue, ladies and gentlemen, on diagnosis, because it's a very important aspect of understanding the DSM. Let's continue. Now, the diagnosis is also important in that people must be viewed within a context. So diagnosis is contextual. Diagnosis is contextual. You diagnose, you tend to formulate a hypothesis about a person in their context. Let me repeat. You tend to formulate a hypothesis about a person within their context based upon their presenting narrative. So you need to consider the environment, the role of nurture-nature paradigm in the environment. How does nature and nurture interact? So even looking at the models of psychopathology, you are taking those models into consideration and looking at them integratively. So, diagnosis also is cultural. It's not only contextual, but cultural. Cultural. The role of culture and cultural formation is important. The role of culture and cultural formation is important. There must, let me emphasize the word must, be consideration of the person's cultural background on diagnosis and treatment, as per the DSM-5. In the DSM-4, it was mentioned, but this is now what you need to do. That is why there are now measures that are used to measure that. Now, there are several aspects of cultural formulation, which I'll give you as per my notes. Please take notes. And you can listen to the tape later on. But let me give it to you, please. 1. In the DSM-5, under diagnosis and culture, there is reference to what is known as the outline for cultural formulation. The outline for cultural formulation. It provides a number of guidelines to assess the person's cultural identity, the client's nature of cultural distress, as per the culture-bound syndromes, the psychosocial stressors within that culture, the psychosocial stressors within that culture, and the cultured factors that impact vulnerabilities. So the diatheses, if you recall, stress model. Yes, Mr. Barr, otherwise mad cow disease. Very good. So the diathesis model is looking at the person's proneness, predisposition to vulnerability. Now that is why we do developmental psychology, psychopathology initially, because this is the precursor. Developmental psychopathology is the precursor for adult disorders. On Mutualite, is that clear? Any questions?
Can you repeat that, Dr. Mark?
Repeat what? I said a lot.
The last thing you just said. Precursor to adult disease.
No, the precursor to adult disorders.
Adult disorders.
Yes. If you understand developmental psychopathology, the path of multifinality versus equity. You remember that I talked about that before?
Yes, Doctor.
It is what it is. So, also what's important, and it's not been underscored, is the therapist patient, are they compatible culturally? So in other words, it is important for there is to be a match of cultural match of the therapist and the client. Because sometimes, in some cases, if you don't understand the person's culture, to work with North Indians or people of Aborigines in other countries, you have to understand your culture. You may not be that in terms of the ethnic matching, but you have to understand at least understand your culture or be sensitive to changes in your assessment and diagnosis. So then the factors then in the outline for cultural formulation that the therapist, the psychotherapist or the clinician, I should say, has to take into account is the cultural identity of the client's cultural conceptualization of the distress. What is the client saying to you? How are they manifesting their distress? What are they telling you within their context, within their culture? I'm on 2 now. Formulation in terms of culture. There is where culture is based upon client characteristics. And if clients are different in how they in culture and context, one way to manifest or one way to understand the dynamics is to use what is known in under 3 cultural formulation interview. The cultural formulation interview. It is a semi-structured interview. It is semi-structural, or structured rather, which of 16 questions that seeks to obtain information primarily about the socio-cultural functioning, how the client is perceiving their problems. How the client, this interview schedule seeks to provide an assessment or an understanding of the patient or the client's perception of their problems. Is there insight? Do they understand what is happening to them? There are 4 basic domains of this interview schedule. 4 basic interview domains. One, a cultural understanding of the problem. Is the patient running amok? Is the patient having a culture-bound syndrome that they're dealing with? Are they nervous in the context, in the culture? So it's now the understanding of the problem. 2, there is the perceptions of cause and effect in the culture. The perception of cause and effect in that culture. Cause and effect in that culture. Does the person in their context, do they have social support? Very important. Because it's going to provide an indication of prognosis. Will they get better later on? Or will they remain disabled? Are they likely to get better? Or will they remain disabled? The cultural factors of coping, how do they cope? Is it a dissociation disorder? Is it a fugue? Is it an amnesia? Is it a conversion reaction? How do they cope within the culture? In North America, people binge eat. People have emotional eating to cope. People also develop, in my experience here, they develop severe obsessive compulsive rituals. I have a patient who I'm treating who has not left his house for 2 years because he's afraid of germs. He's afraid to open his door. He's afraid to, once he goes out, he thinks that once he steps on the floor, he can't eat. He's afraid to eat because he's going to be poisoned. He's afraid of getting sick. those are disabling within the context of the patient. Has the person had a history of seeking help before? Has the person had a history of seeking help? Because some cultures, some ethnic cultures can underutilize or overutilize the mental health systems. Some people can under or overutilize the mental health services. Some ethnicities, I should say. The third I would like to share with you, ladies and gentlemen, is what are known as cultural concepts of distress. Cultural concepts of distress. Cultural concept of distress. Now, the DSM-5 definition of this is that these are ways or means that cultural groups experience, ways or means that cultural groups experience, understand, and communicate what's wrong with them, what they are feeling. So it's more the phenomenology of their experience, their feelings, their thoughts, the phenomenology of experience. Good. The phenomenology of their experience. So it helps the clinician to understand the phenomena of the patient, to experience it by empathy, understanding. You don't have to, you must have empathy to understand what the person may be going through. You must be able to interpret what they're experiencing. And there are three types of concepts of distress in this third tool. Three types of concepts. I should say. Now, cultural syndromes. Cultural syndromes. What are these? These are clusters or characteristics of mental disturbances. Let me repeat. Clusters or characteristics of mental disturbances that primarily exists within a culture. Note, primarily exists within a particular culture, not just any culture, within a particular culture. And they are recognized by members of that culture as atypical. They are recognized, symptoms are recognized by members of that culture as atypical. In relation to a normal behavior. Now, we did talk at length in previous classes about normal versus abnormal behavior. We did talk about that. This is what this is looking at. Whereas before the DSM-4, it was just they talked about it, but now there is a great emphasis on the socio-cultural formulation of the patient or the client in diagnosis and assessment. So B, and if you have your DSMs, you can, and I Mr. Nyami,
Yes,
hello.
I'm here. I'm here.
I believe I sent that. I had sent that those types of culture-borne syndromes to you for uploading, please, for them to see the types of what we have. But basically, they are the types. So I've defined what that is, and so it's for them to be uploaded. Now, under the syndromes are the syndromes are the process. Note, the syndromes are the process. Now, the second is the cultural idioms of distress are the procedures. The procedures. And these are means of relating symptoms. This is how you maintain. So when you do an MS, mental status exam, you have to know the patient's behavior before you. What is it communicating? Tears mean something to a patient. Tears can mean distress. Tears can mean relief. Tears can mean pain. But what is the patient's subjective phenomenological experience or cultural idioms of distress? How are they manifesting that? Tears is a sign to you. Tears is a symptom of depression or a symptom of some problem in the environment. On you to Max. Any questions?
So, Dr. Mac,
Yes.
what if tears is not a symptom of those things, but a sign that healing is taking place? Could that be cultural also?
It could be, yes. Tears could be a sign in the context of therapy that you have reached, there is an insight.
Right.
Or tears could mean that the patient is in pain and would like to discuss it. So the therapeutic experience or the therapeutic engagement brings out that emotive response by your presence, by what you stand for the patient to be able to express himself. Any other question? Good thought, good comment. Any other question?
For me, again, Dr. Mac, I think culture goes far away, and not just ethnicity, but also the culture of maybe a workplace and a culture in terms of.
Explain, Mr. Barr. What do you mean?
For example, you can create a culture
Yes.
within a counseling environment, one of trust, one of honesty.
Yes.
And it is not necessarily that the person coming to counseling would have that experience in their normal day-to-day life.
Yes.
So you have reshaped or recreated a culture for that individual within the therapeutic environment. For me,
be
culture
careful because yes, but be careful because culture, it doesn't mean that because you create a therapeutic environment is culture. In other words, the patient brings their cultural idioms of distress and their the culture and the context. So the therapeutic doesn't necessarily mean that it's cultural. In other words, you are there as a blank slate to be able to interpret what their existing phenomena may mean and how you interpret that in terms of sensitivity to the experience.
Okay, appreciate
But
that.
it's not itself culture. Be careful. Anybody else? Anybody else?
No questions for me, Dr. Mack. It's clear.
It's clear, everybody? Hello?
Yes, Dr. Mack, it's clear.
Okay, let me continue under the same three. The third is known as it's called cultural explanations. cultural explanations. You have to look at what is known as explanatory models. Explanatory models that members of a culture use to explain meaning. Now, let me explain what I mean by that. If you work with Asian clans and Japanese, Chinese, one of the basic tenets of their culture is politeness, deference to authority, deference to authority. So a patient who avoids looking at you and hold their head down doesn't mean that they lack self-esteem. It means that they're respecting your authority. So that is what is known as the explanatory model. They use the schemas or the gestures of their particular context for them to be able to communicate. So shifting eyes mean that in certain cultures, here may mean paranoia. It does not mean that in the Asian culture. It means deference to authority and to your power in the therapeutic relationship. On mutual max, is that clear?
Yes, Dr. Mark.
I know that Jamaica is very homogeneous in terms of blacks living there, but you need to be exposed to other types of culture should you be able to work with these people. That's why you do the courses in culture, to understand that if you work with other populations, you are going to find differences. And if you're not understanding, you're going to end up in trouble.
That's true, Dr. Mark.
Beg your pardon?
I'm saying that's true.
It is very true. And even certain subcultures of populations, of groups, you have to understand how to work with them. All right, let me continue with the explanations. That this is more reflective in cultural symbols, cultural gestures, demonstrating the causation of symptoms. The causation of symptoms, illnesses, and distress. Causation of symptoms and distress. So that is it is for cultural formation on a diagnosis. I'm going to still continue. I'm going to continue. Now, psychiatric diagnosis serves two main purposes. Because you can have medical diagnosis, you can have other diagnoses. Let me be very blunt. You deal with psychiatric diagnosis in your training. That's what you've been trained for. To deal with psychiatric symptoms.
Dr. May I just say something 1 minute, just for clarification?
Of course.
We were actually doing the 4 basic interview domains. So we were at number 3, which we were actually doing the 4 basic interview domains. And so the last one, which was 3, cultural concept of distress, where we listed out the last ABC, was for 3.
Was cultural explanation.
Cultural concept of distress was number 3 of the 4 basic interview domains.
Yes, but under the cultural concept of distress, there are 3 subs, and I should have been probably more.
You gave us those 3. You gave them. You gave us.
Yes.
You gave us those 3. A, B, and C. So where are you going to know? Number 4 or continue?
Yeah, I looked at diagnosis as culture, and I'm continuing. I'm not done with diagnosis. I'll let you know when I'm done with diagnosis.
Okay.
So what I'm saying is that there are 2 psychiatric diagnosis serves 2 main purposes. That's what you've been trained for as clinicians. 1, that when you do counseling or psychotherapy, you are being exposed to the operations or the mechanics of diagnostic category. You are being exposed to the operations of diagnostic category. That is, you are interested in the natural course, history of the disorder, complications, etiology. That's why we did you understand why we did the presentation, and that's what you're looking at. So the natural history, etiology, course, the criteria of the diagnosis, prognosis. We can't do without to treat. We must have prognosis. Is this person likely to get better? So prognosis means that the problem is either resolving or evolving. Prognosis means that the patient, or the symptoms, I should say, are either resolving, that is going away, or evolving, getting even much more worse. I'm still on the one. Diagnosis should reflect, again, as I said, the origins of the etiology and the pathogenesis, course of the condition, the course of the condition, course of the condition. Give me one moment, let me organize myself. Secondly, diagnosis has predisposing factors. So another one, looking at it in terms of predisposition, in terms of family history. Very important to ask, because you get a sense whether or not genes play a great role in this person's presentation. Genetics. So the diagnosis is plays heavily on predisposition to genetic influence. So the genetical influence is also linked to environmental stress. And we do know from history, from research, I should say, that schizophrenia people tend to have relapses when there is high emotional expression in families with schizophrenia. That's why when people are treating schizophrenic patients, they focus on the family, because the family can be the cause of a patient relapsing and going in and out of hospitals. Any questions? Any questions?
None for me, Dr. Mark.
Beg your pardon?
I said none for me.
Okay. Let me underscore. I was looking when I found it. Then another I'm looking under one. Let me add something else called the pathoplastic factor. Pathoplastic. We had a psychogenic, looks at course of disorders, etiology based upon genetics and family. Let us now look at the pathoplastic, P-A-T-H-O, plastic factors. What is this? It is the uniqueness of symptom expression. Now, as I told you before, the DSM has a group or clusters of symptoms. No one person manifests the same symptoms. That is called pathoplastic. Uniqueness of symptom expression. So you need to be able to understand the DSM and the diagnostic criteria. So ladies and gentlemen, if I were you, I'd start to understand the DSM, that you know it in your heads. When you see a patient, you know exactly what you're going to see, what are the symptoms, and you're going to validate those symptoms with the DSM. They must call it in the rest that the horse must always drive the buggy. It's not the buggy driving the horse. You can't go to the DSM to apply it to the patient. You must apply for the patient. These symptoms fit this criteria in this category. If it doesn't, it's not the same. It's not the disorder. It's something else. So you're looking at uniqueness of symptom expression in the patient, and you're looking then at how is this disorder manifesting itself to you. How is it manifesting itself to you? What type of signs it is? Is it a perceptual disturbance? Is it euthymic mood or normal mood? Is the affect constricted in range and quality? Is there temporal orientation in terms of oriented person, place, and time? What is your name? What time is it? What day is it? What day of the year is it? In other words, is the person oriented within reality? These are what I call pathoplastic. Is the person engaging in word salad? How is the person's thought patterns? Is there word salad? Are they repeating things back to you? Echolalia in autism spectrum disorders. Those are the pathoplastic factors. Unmute your mics. Any questions?
None from me at this time, Dr. Ma.
Any questions, ladies and gentlemen? No questions.
Okay from me, Dr. Ma.
Okay, let's continue on the second purpose of psychiatric diagnosis. We did the first, and we talked about the main tenets, which are the pathogenic, the pathoplastic. Very important. Let's look at the second purpose. Is basically what is simple. How are you going? You have now determined you have determined from hypothesis to case formulation by fact from the DSM diagnostic criteria. You're moving to diagnosis and to prognosis and then to treatment. You're going to say, how am I going to treat this set of mental phenomena? So diagnosis is interested then in symptom reduction. It is interested in how are you going to make this person feel better. You want to reduce the distress. You want to reduce the idioms of distress. You want to be able to help them use their explanatory models to express themselves, to tell you what the problem is. So you need to be understanding about not only to reduce the symptoms, but to be able to understand the severity of the problem. Is the problem mild? If it's mild, then we're looking at adjustment disorders, depressed mood, anxiety. If it is moderate, then we're looking at symptoms that are somewhere between a spectrum of that has a little bit more difficulties. And so we can probably look at developing persistent depression, otherwise previously known as dysthymic disorder. So therefore, severity of symptoms. Note carefully. Severity of symptoms determines prognosis and eventually disposition to resolution. Let me repeat. I hope I remember what I just said. Brilliant. That the severity of the problem is tantamount to understanding the ability to differentiate between the various shades of severity. Is it mild? Is it moderate? So most disorders in the DSM have a range of mild, moderate, or severe. If it is severe, if it's mild, we are looking at degrees of severity. Degrees of severity leads to prognosis. Is it guarded? Good. Or is it excellent? Guarded is serious, and guarded means that you just don't know. The symptoms are such and so severe that it's unlikely to provide relief in 4 to 6 months or a year. The matter of symptom reduction, we haven't talked about treatment much in this class because it is really not a treatment class. We can talk a little bit about treatment. When we get to child and adolescent therapy, we will look at that much depth. How many people have not taken child adolescent therapy? Unmute your mics.
I haven't done it, Dr. Mark.
I haven't done it, Dr. Mark.
Okay, so when we get to that, God willing, we will look more in treatment. This is more as an assessment diagnostic class. So we won't emphasize treatment much in this class. Your goal, your role in this course is to be able to provide an informed diagnosis, understand phenomena, and put a label to it. That's all you need to do right now.
Okay,
but in case of the diagnosis anyway, for future reference, just know that treatment, you must be able to treat the patient. You cannot not know what to do. That is why the curriculum, when I made it up or when I created it, was geared specifically to help you to be able to look at the patient and treat them. All your training in 2 years, 2.5 years is 90 minutes or an hour. That's all there is. And I said it before, 90 minutes where you assess the patient, make a determination, and treat. So it involves preparation. Treatment involves predictability of the process. Preparation in terms of your gathering your skills, predictability, and also probability or possibility for reduction. That's what it is about. That is what you do when you do diagnosis. That's why you're here in this class doing this. That's why I'm pouring, that's why I'm giving you so much, because it is what it is. People expect you to know what you're doing when you see them. They don't care what GPA you have. They don't care what course all they want to know. When I come to you, will you make me feel better? Well, if I open up to you, that's all. That's not what it is about. Unmute your mics. Any questions? Is it clear by your silence? Are you saying that you're confused, or are you clear?
Clear, Dr. Mark. I'm clear, Dr. Mark.
Anybody else?
It's clear, Dr. Mark, just a lot to taking at one time. I guess we have to digest it and come back.
We had to have another class. I know it's a lot of work. I know this is why we had to have it separate. It's a lot.
Yeah.
But I'm doing but you have the tape to go back to and listen. But it's a lot. But remember, always remember that patients don't care what degree you have, whether it's honors, as long as you have the resources within you to trust your instinct, trust your judgment, trust your gut to interpret signs, to show empathy, provide a possible treatment outcome. That's what the patient wants to hear. So even though I'm giving you all of this right now, it is based upon your ability to have good diagnostic skills. You know what I'm going to do, ladies and gentlemen? I'm going to have Mr. Nyame, I'm going to send you my notes. Is it acceptable? On diagnosis.
Very much so, Dr. Mac, please.
Because I would like to go on to something else.
Yes, thank you.
Are there any objections?
That's fine with me, Dr. Mark.
That's quite fine with me.
That's fine with me.
Now, Mr. Nyame.
Dr. Mark, Victor
Mr.
said that he's clear.
Yes, Mr. Barr.
Okay, I said Mr. Nyame just quoted. Victor said that he was clear.
Okay, good. I saw that. Thank you. Mr. Nyame, I wanted to just test the students. I know there were some little mini videos. I believe I sent it to you. Can we just put it up that we can test the students to see if they have grasped the 5 diagnostic types, please, before I go on to mental status exam?
Let me go and try and locate it, because I'm not sure. Describe them for me.
Okay. I will send it to you by email. It's probably easier. Oh my gosh, I had it out. Could you bear with me? Let me find it in my notes, please. Just a moment. I sent it to you. It says these are case veneers, little mini case veneers. Do you see it in the Saturday? Do you see it? I sent it to you. Hold on, let me see if I can find it.
Because I get a lot of stuff.
I know, I do, I know. Okay, it's called Mini DSM-5 Case Veneers. All right, I'll send it to you. I'll send it by email now. Can I send it to you by email? The students can have it up that they can see it?
Yeah, please.
To test, to give them practice?
Yes, yes.
Okay, let me send it to you now, please. Just a moment. Any questions in the meantime, students, while I send this to Mr. Nyame? Any questions, any criticisms, any comments? Any questions?
Yes, Dr. Makito.
Yes, go
can
ahead.
you please repeat the first
Go ahead.
type?
Go ahead.
Can you please repeat the first type?
The first type of what, Mr.
Yes.
Of first type of what? I said, what are you talking about? What are you making reference to? Hello, are you there? Mr. Hello? I'm not hearing you.
He's stuck.
Okay, I'm not certain what he's asking. That's why I'm a bit confused.
He's stuck. I don't think he's hearing.
Oh, he's not. Okay, ask him. You can someone type that and ask him.
I'm just
Is
wondering
it
if
you refer to the 5 diagnostic types that I gave?
Yes, I'm just wondering if that's what he's thinking.
That's what I suspect.
Yeah.
I think his system has stuck, so he probably can't even respond to you yet.
Oh
Maybe
dear, I'm so sorry about that.
He said to the side, yes, Dr. Mac, to the side. He wrote that.
Beg your pardon? Let me go back to the, hold on, let me go back to the Google. Let me go back. Oh, okay. The first one, if I think you're talking about the diagnostic types, I said the first, I have to go back. The first one was functional. I'll type. Functional. Mr. Gaia, is that what it is? You can type and I'll go back and explain. Okay, do you want to know what it means? And maybe for the group, I said functional. I said the functional type of diagnosis is what is found in the DSM categories, or some DSM category, and it's really non-organic. It is more based upon a combination of physical and emotional symptoms. It's not rooted in the rest. There is really no physical, or there is no brain-based cause. It is more emotional. So functional, so you can have your dissociative disorders, the trauma-related disorders. These are functional because sometimes they are not necessarily based on any physical symptoms, but they're emotional. That's why it's called functional. No, I'm not hearing you. So you can type your questions if you need to ask more questions. Mr. Nyama, you said he's not hearing. Could you assist, please?
I can't really assist him.
Sorry?
Hello, you hear me now?
Yeah,
you hear me now?
Yes.
Okay, thank you. That is what I was talking about. Thank you.
Is it clear? Is it clear?
Yes, Dr. Mark, thank you.
Okay. Thank you very much. All right, let's continue. Let's now shift gears a moment. Did you put it up from Mr. Nyame?
It's coming up. Let me I soon share it on this.
And students need to prepare now to apply what you've learned and stagger me with your precision of brilliance. Is it coming up on the screen?
One moment there, one moment.
Okay. Any other questions while he's doing that, anybody? Oh, by the way, let me say this, that the post, this is going to be the final post for the course, and I'm going to give the liberty of extending it to Wednesday for the first post and Thursday for the second post. How is that?
That is fantastic, Dr. Mack.
That's great, Dr. Mack. Thank you.
Thanks,
Dr. Mack.
Okay, thank you. Very good.
That's for Dr. Mack. Thank you.
You're welcome. So it is a free for all. I didn't give you any. I did not give you any deliberately didn't give you anything to react to. It's for you to react on what you have learned, to show me that you have learned from the course, that I have not taught you in vain and taught you rubbish. So now I know some people had challenges. I'm still looking at 3 and I'm not seeing where it's complete. Some people have not yet added their posts. I know of some people who have had challenges. But for those who have not spoken to me, I assume that you need to be posted. But I'm giving you permission to post Wednesday for the first post, ladies and gentlemen, and Thursday. May I also suggest, while we're doing that, is that again, I find that wrapping up, this class is coming, so I'm going to offer you again to really go into some disorders in detail. I don't think with our presentation on Monday we're going to go into that much, because as I said, we didn't have a class last Saturday, unfortunately. So I'm going to bear your indulgences for one last Saturday class to go through some DSM-5 in depth. How is that? People?
That's fine with me, Dr. Mark.
Okay, because it's important for you to understand and some practice.
Would that be the 20th? Dr.
Sorry?
Mark, would that be the 20th of December?
Well, today is the 13th, so yes.
Yes, it could be a little challenging for me, Dr. Mark.
Oh dear, I don't know what to do then.
Because I wasn't planning to have classes down to that time, so.
Yes, I know, but then with the missing of the class, that has forced me into this conundrum, into this situation. So I don't know. Because Mr. Nyame, you're not available during the week for that. Apart from Monday, I know you are busy with other things. Can you make an exception?
If I'll have to consider Wednesday.
Ladies and gentlemen, did you hear that? Did you hear? Wednesday?
But the others haven't spoken about Saturday yet, Dr. Mark. I don't know if they're
Anybody else has any objections to Saturday?
Saturday's a bit challenging for me, Dr. Mark. Wednesday would be better.
Oh dear. Okay, we're having some difficulties with finding the time.
If we have the class on Saturday, I guess I won't be able to join from the beginning.
Okay. And how many people will be able, because I don't want the last time when we had no audience and only Mr. Nyaman and I found that the time was wasted. So I'm trying to guard against that. I know people have making allowances and I appreciate, but this is a very intense class, as you can see, a lot of information, and it's the crux of your coursework in the program. So I need to know. Mr. Barr says that it's good with the class, not certain what he means, if it's Wednesday or Saturday.
No, it was Saturday after, man.
Sorry? Saturday. Okay.
It was on Saturday.
Victor, he's asking about recalling the 5 diagnostic types. Well, okay. As I talked about, the 5 diagnostic types was 1 functional. Is he hearing, Mr. Nami?
Yes, he's hearing.
Okay, functional. Number 2, let me go back to what I had them in order. I had them in order. Let me go back. Bear with me, please. Functional, just a moment. Psychosis, neurosis, organic, and neuropsychiatric. I'm going to send these to Mr. for student ref. I'll probably send it to you directly, the notes, rather than have them posted. Okay. Anything with the things on Mr. Nyame? Still waiting?
Can you see the screen? I have shared my
screen. Click on you?
Yeah, and see. Okay. I hope it works. Last time it didn't.
Not certain.
Not working, Kojo. Clicking on you, nothing.
Oh no. Alright then. I'm going to have to make a link to it again. You may have to download it. Alright, let me work some magic again. I'm gonna put it on Google Drive and share it in here so that you can click on the link.
Good.
Dr. Matt?
Yes. Miss Osborne, yes.
I'm beginning to get a little anxious.
Mm-hmm.
When I heard you ask about Saturday class for 20th of December.
Yes.
Because in the back of my mind, I am thinking the 20th of December I could start my celebration because all the assignments to be given
Okay.
completed. So I don't know. I'm a little bit blown away at this time. I don't know.
You don't know what?
No, in terms of the amount of material that is still left to be
Well,
interviewed.
this is just primarily, this class probably won't be as long as before. It's just to look at some disorders in depth. Because it's so vast, we can't cover all the categories. It's just basically impossible. So, it's up to students. I mean, there are other ways of doing it, like recording it without an audience. But the problem is that we wouldn't have an interaction. So that's the issue. But I doubt with the presentation we're going to have that time. We're just not going to have a time to go in depth. Now Wednesday seems, I don't know, some people are saying they can't make it Wednesday. I don't know.
Wednesday would have been fine for me, Dr. Matt, but I'm not so sure about Saturday. However,
Well, it looks like Wednesday during the week. Okay, anybody else can make it on Wednesday.
we're not hearing from the others though.
I can make it on Wednesday, Dr. Ma.
I'm not able to make it on a Wednesday. Saturday is more feasible for me.
Okay, so people are saying Wednesday. So it looks like we may have to try.
Wednesday, Dr. Mac, Wednesday is fine with me.
Okay, well, we have a consensus. Wednesday, then, ladies and gentlemen, we'll have the final class. Ms. Osborne, you heard that?
Yes, Dr. Man.
Are you okay with that?
I'll try to make it on Wednesday.
I won't be able to make it, Dr. Mac.
Who is that?
That's Hoya.
Okay, you can't.
No, Dr. Mac.
Okay, well, you know that you are responsible for the audio lecture.
Yes, Dr. Mac.
By the way, the exam is now, Mr. Nyam has the exam and it's loaded. Basically, there are, if I recall, there are two major cases, one child, one adult, and 4 questions you have to answer one. Are you hearing me?
It's Dr. Mark.
Yes, Dr. Ma.
So this is why we need to practice with these cases that you can be able to do well. And that's why I'm very anxious about that.
So Dr. Mark, you're saying we have to answer 3 questions, 2 cases and 1 other question?
No, I said 4.
4, okay.
Choose from one from the adult or child category, and you can use whatever resources at your disposal to answer the question, as long as I see proper referencing of the material. Now, I don't want a book. I don't want 100 pages. I don't have. I just want at least you answer the questions. You had liberty to with 4 questions, 2 cases, 2 questions, essay. Okay. That's it for the course. Plus the movie reference. By the way, again, people, before I click on, it's ready on your right hand. People are saying, have been saying that they cannot find the full movie. I have checked myself, and I was surprised that it says not available in my country. So I don't understand, but I do see it in chunks. So if people are having trouble with that, then I have no choice but to receive it in pieces. If you have difficulty, is it clear?
Yes, Dr. Mark.
I'm not sure what you're talking about, Dr. Mark. Sorry.
Talking about the movie that people have been saying that they cannot send the whole movie in its entirety.
Okay.
But there are segments on YouTube available. So if you cannot, then I will have to accept the parts of it. But I know the movies are there.
Okay, Dr. Mark.
Okay, let's click on the, because time is going, let's click on the interview, click on the mini.
I won't be able to make it on a Wednesday, okay, Dr. Matt?
Who is that?
Bar, won't be able to make it on Wednesday.
You're excused, Mr. Barr, for this.
I appreciate Dr. Matt.
Okay, ladies and gentlemen, it's up. Let us look at the examples corresponded. Now, all I want you to do, I'm not asking you for a diagnosis. You're not ready for that yet until we do the case conceptualization. All I want you to do is give me the diagnostic type. All I ask you to do, and just tell me what you're seeing that led you. Tell me the symptom, the mental phenomena that led you to make that distinction. So let's look at case study number 1. Are you seeing it?
Yes, Dr. Mark.
Take a moment to read it.
I am not seeing it. Not sure what I have to do.
Click on
your right side.
The chat. Go into the chat and go to the left side first, and the chat is at the top when you move your screen, move your mouse.
Okay.
Yeah, when you click on that, it's on the right. It's going to come up on the right. It's a link. I had said, please click this link.
Okay.
And it's a preview. Yes.
Okay, I'm in. Thank you.
Good. Okay, take a moment to read. The key to reading a VINI: date of onset, age of onset, duration of onset, time of onset. This woman is 28 years old. So think about what are the extenuating factors. Are they precipitating factors, perpetuating factors, predisposing factors, absence of protective factors? And tell me what so tell me what the diagnostic type is. And give me a little bit about what you're thinking. Don't give me the DSM-5 diagnosis. You're not ready for that yet. Age of onset, time of onset, duration. Are we done? All right, I've looked at it and have the information in my head. Are you ready? Let's go. Age of onset. What do you notice about the VINI that strikes you as a clinician seeing this patient for the first time? Signs, ladies and gentlemen. What are the signs? Symptoms.
Irritability and withdrawal.
Make note. So when you're looking at the patient's narrative, begin to look in your mind for what category of disorders will have that irritability. Why is she irritable? Is there anything in the VINI that will suggest irritability? What is making her irritable? What are the precipitating factors? Do you see evidence of that in the VINI? Is it predisposing? Is it perpetuating? Is it absence of protective factors? What's making her irritable?
Well, she seems to be disappointed in her performance, that she hasn't been performing as well as she used to in the past.
But that would make her irritable, would it? That would not make her irritable.
She has high standards, Dr. Mack, and is a little critical of herself, and tends to be feeling a little less than how she would normally feel, and also the same issue with her inability to perform. So because she has high standards and she is not performing as she should, that could probably result in her feeling a little irritable.
Yes, but what you're doing is that what you're looking at causation.
Oh, okay.
What I'm looking for are symptom acuity, evolving symptoms. What it is in the beginning that suggests to you that first of all, what diagnostic type it is. What is it? What is it telling you? What are you seeing? All that is saying to you of past premorbid functioning. This is known as what you just said to me is known as premorbid function.
Okay, Dr. Matt. She seems to be having a little functional issue, Dr. Matt.
Functional.
Yes.
Explain.
Emotional.
Yes.
It has nothing to do with her brain or anything. It's non-organic, Dr. Matt. So it's mainly
emotional.
Disturbances that she could be having.
Yes, but just a moment. But when you look, but the key is for the past few weeks, duration of symptoms.
Okay.
He felt fatigued. One symptom.
Okay.
He has struggled with feelings of worthlessness. Another symptom.
She's also reported sick.
Due to her inability to perform well as in the past, premorbid function. So those are symptoms. Signs to you. She called in sick 7 occasions. So she's having little interest in sex, difficulty falling asleep. Those are symptoms. So look at symptoms. Look for symptoms driven. Is it externalizing or internalizing? Let me ask. I'm applying what you have learned to this. Externalizing symptoms or internalizing?
Internalizing symptoms.
Beg your pardon?
Externalizing, Dr.
Internalizing symptoms.
Externalizing.
Externalizing.
Okay. Why externalizing? Why externalizing?
Because people are taking note of what is happening.
Yes.
If it was internal, then nobody would necessarily see it.
Yes.
But people have seen the changes. Her husband has seen it, the workers have seen it.
Yes.
She also has some elements of internal going on, Dr. Mac, because she also has some suicidal thoughts.
Okay. And stop it right there. Note, suicidal thoughts. If someone has suicidal thoughts, ladies and gentlemen, what would cross your mind? What hypothesis would cross your mind?
There's some distress.
Yes, good.
And
what else?
She's feeling depressed, Dr. Mac.
Yes. And is the depression caused by so the depression couldn't be caused by high standards, it's caused by something else. What is it causing it?
Maybe some kind of stressor in her
No. Well, what are the stressors? It's right in the beginning. Is it predisposing, perpetuating? I am suggesting, let me help you. I'm suggesting that it's precipitating. In other words, the symptoms are acute. They are just beginning to come in. Why? Because for the first few weeks, duration of onset, she felt fatigue. Why? Because she has a high stress job and she's beginning to feel burnout. So she's beginning to now, based upon past experience, when she had been high performing, that's her style, that's her relationship coping style, that's her personality, perfectionist. But that's not the issue. The issue is right now at this point, few weeks afterwards, she starts to feel worthless. She starts to feel shame about her ability to perform. She has difficulty. She's fatigued, difficult to concentrate, and she's irritable and withdrawn. Is that somebody who was high performing before? So in a vineyard, you are looking at past function and making to what you're seeing now. Is that cause for alarm for your clinician? would that be cause for alarm?
Yes, Dr. Mark.
Yes, Dr. Mark.
So if you are looking at withdrawn, irritable behavior, fatigue, worthlessness, what particular disorder category would bring all this? This is why I want you to be able to know the DSM at some point in your heads. Tell me what category of disorders will bring this on.
The depressive disorders, Dr. Mark.
Ah, I feel like I have a lovely glass of wine. You have the enjoying lovely Portobello steak. Incidentally, I had a lovely lobster today for my.
Oh my goodness. Dr. Mark, don't talk, don't talk.
She wants to make us drool.
A bottle of wine in my fridge, and it's time for me to drink it.
Lord, Dr. Mark.
Celebrate.
Oh my
brilliant.
God.
What? I mean, a little 1 pound lobster is, I mean, nothing. There'll be more on sale for me to have to enjoy the students' brilliance.
Yes.
Wonderful.
Yes,
I'll have a glass of wine to cheer you on.
To cheer you. Okay, Dr. Mark, cheers.
You see what I'm talking about, ladies and gentlemen? Let's get. Do you see what I'm talking about? What are you noticing? That you have to look at 3 things. Age, she's 28 years old. You're looking at pre-morbid function, known as pre-morbid function. So you're looking at what is a precipitating factor. The precipitating factor is a high-stress job. She can't manage anymore. She's under pressure. So as a result of this, the past few weeks she has developed symptoms, acute symptoms that shows to you symptoms: withdrawn, irritable, feelings of worthlessness are signs of depression. He stays in bed all day watching TV or sleeping. Is that normal, ladies and gentlemen?
No, Dr. Mark.
Okay. So that's what you focus on, symptoms. Look for symptoms within the vineyard. Now, someone said that it's externalizing, true, but what is the diagnostic type?
Functional.
Explain.
Well, she has emotional issues, Dr. Mark, which we just identified in the symptoms. Well, clearly there's no brain-based disturbances there, and there are environmental stressors. She has environmental stressors, which, as you said, the precipitating factor is her high-stress job.
Yes.
So that's what I'm thinking of.
Okay, anybody else? Anybody else?
I would agree with Michelle, Dr. Mark. It's mainly psychosocial. There seem to be no organic or brain-based factors involved, so I would say it's functional.
Okay. Anybody else? Anybody else? All right. I will end your anticipation. It is actually neurotic, but I tell you why. With a functional diagnosis in a case like this, you would probably be seeing where she's having aches and pains. What you're seeing are actual manifestations of a mood disturbance. How do you know it's a mood disturbance? Because the symptoms that she has been reporting are worthlessness, but she is self-reporting. Now, in a functional disorder, the person is probably unaware of what they have experienced. So in a disassociation, or somebody who has who may have a generalized anxiety disorder, they may not be able to say what the problem is. She's able to say that. So in other words, this is neurotic in that there is evidence of the interaction between environmental stressors of the person, environmental stress, and that the person now there is clear evidence of impairment in function. So a neurotic tendency is that it's non-psychotic, but that there is ego dystonic behavior. In other words, there is disturbances in coping skills, and there is clear evidence in function. Do you see that? What is a dysfunction? When you compare a married female, a medical resident who was high achievement, she's now deteriorated or deteriorating or decompensating. Do you see that?
Yes, Dr. Ma. I'm not sure. Okay.
Yes.
For the neurotic, you had said internalizing factors or experience. I can't remember how you pronounced, because somebody said earlier that she was experiencing externalizing factors.
Yes, she is.
But for neurotic, you had said when you were giving us the notes that they experience internalizing factors.
Yes, it is. But in this case, and I should have mentioned that that in a depressive disorder, there is both internalizing and externalizing. In this case, what she's experiencing, people are not as signs. Pay attention. This is a sign to other people. Irritability is a sign. Withdrawal is a sign. What else? Staying in bed all day is a sign, and sleeping are signs. So those are signs of disturbed behavior within a context. A medical student who is high performing doesn't sleep all day. Do you see that?
Yes, Dr. Ma.
Yes, Dr. Ma. So you're saying for depression,
yes,
under the neurotic type, that the person can experience both internalizing and externalizing
I should have
factors.
made that clarification, and that's my mistake.
Okay, doctor. Thank you.
There is clear internalizing and externalizing behavior in depressive episodes. All right,
and in her thoughts of suicide.
Yes, and that is even serious, because when a person is wanting suicide, even a mental status exam, you have to be able to assess it and determine, is she going to hurt herself? But let me hurry up, do one more, and then let's run to the mental status exam.
Dr. Mark.
Yes.
Dr. Mark, before you move, forgive me if I am wrong, but I don't think that she wanted to commit suicide.
Where is that?
Said that although she has not.
I don't see that. I'm trying to figure it. Oh, the last paragraph.
The last paragraph said that she has thoughts of it. Thoughts. Considered.
Well, it says she hasn't ever considered suicide.
And it's frequent thoughts as well.
Mm-hmm.
The thoughts.
Not frequent thoughts?
Okay.
Frequent thoughts.
Yeah.
Okay. No. This is important, because I'm glad I saw this. Hello, anybody, people with a depressive episodes, you must assess for suicidal lethality. You commit a grave, egregious sin if you don't, and you'll get in trouble. As someone said, and I think I said it, wrong diagnosis, wrong prognosis, wrong treatment, but right suing. You have to be able to look at that. So in this case, where she's wishing that she were dead, is passive ideations. These are passive death wish. So even though the person may have thoughts of suicide, suggests that you want to know, are you going to take, you have it in your head, are you going to carry it out? So this is a key to the fact that there is depression. And so neurotic more is likely to deal with ego disorders and a direct an inability to function psychologically. That's why it's neurosis versus psychosis. You're in touch with reality, but you can't function.
Yeah.
Is it clear?
Yes, Dr. Mark.
Yes, Dr. Mark,
Clear?
it's clear.
I
Yes, Dr. Mark.
So the second one, and then I'm afraid we have to wrap up. I wish I could belabor the point with more, but I have to get to the mental status exam. Let's do one more, please. Oops. Let's do one more. Let's do case study 2. And Mr. Nami, while you're reading, could you do us a favor to save time? The clips I sent you was a mental status interview.
Interview?
Interview. It's an interview of a clinician with a patient. Could you put it up, prepare for the to prepare in the after this? They can look at it. I sent it to you today. Beg your pardon?
The male and the female. There's a man and there's a Lisa.
Does it say interview?
It said interview.
Look for one that talks about when they're talking together and she's interviewing him.
Yes, they have one.
Okay, just
like that,
pick up any one, please. For that,
Okay.
Doesn't matter. Are we done?
Okay, one moment there.
Are we done?
Yes, Dr. Mark.
Your thoughts, please. Your thoughts.
Well, she seems to be having lots of anxiety.
First of all, determine the age of onset. Always determine
Well, she's 38.
age of onset. Yes. Suggesting.
And she's been having the. Pardon?
Suggesting.
We're in 8 months, for the past 8 months.
Yes, she's been having these thoughts for the troubling thoughts for the past 8 months.
So that's the duration of symptoms.
Yes.
Time of onset.
37.
37.
Time is an age, Dr. Mark?
Time of onset means it is when the problem actually started.
Past 8 months.
Past 8 months, so it could be while she's 38.
Well, of course.
Yes.
That's logical.
Mm-hmm.
That's why I said 37.
But what is it? What is the time of onset?
Adulthood?
Adult.
You have to get this. You have to be able to get this because it's important to be able to diagnose cases.
So the time of, would it be her age 38, doctor? That
no. That's age of onset.
Okay.
Age of is when she was 38 when the problem started. That's age of onset.
Time of onset.
Time of onset is the onset of the symptoms.
That's 8 months.
Okay, so that's the time of onset. Any duration of symptoms, is it, in other words, duration of symptoms looking at mild, moderate, or severe? You have to, it's implied. Is there any evidence of any mild to moderate symptoms? Are the symptoms troubling to her that she can't function?
Yes, Dr.
Yes, Dr. Mac.
How would you put it in terms of range of symptoms, of severity?
I would say they're severe because it's mentioned here that she's had several embarrassing moments in meetings. So I would say that the symptoms are severe.
No, I would say moderate. She's
moderate?
I would say moderate.
She's still functioning. She still goes to work and goes to meetings.
I'd say moderate.
Okay. So severity means what? Okay. Let me. So all right. Severity means. So some people say moderate, severe. Which is it?
Well,
I think it's moderate.
Yeah, it sounds like moderate. I take
Dr.
Eileen's argument that she is functioning to some extent. So I guess moderate would work.
Okay.
I would say severe, Dr. Mark, given the fact that it has lasted 8 months, and despite her best effort, according to the case study, she has not been able to shake those negative thoughts.
Okay. Are there any absence? Are there any predisposing, precipitating, perpetuating, or protective factors?
She's divorced.
Yeah, she's divorced.
Good. So what is that? It's a precipitating factor.
And she has teenage children.
Mm-hmm.
What does that imply, Michelle?
I don't know, Vanessa. I will leave that to you to explain.
Okay.
I figured that might be a little stressful. I'm not sure.
I know that's what you implied.
Okay, so what we're seeing then, ladies and gentlemen, is a woman of divorce. Now, probably not the divorce that is causing this. What do you think is causing her worry?
Well, Dr. Mackett also goes on to say that she had, I'm not quite sure what I say had, a successful, well-paying career, and she's in upper level management. So that means that she really has a stressful job.
Yes.
Whatever it is that she does.
Good hypothesis. Generate the hypothesis. Yes. What else?
And the fact that she has begun worrying about losing her job over the last 8 months would tend. I would think that maybe there's something going on in the company that is worrying her. That cause her.
Now look at this very carefully. I want you to look at this. That time of onset. So for 6. So in other words, at age 32, that's when the problem really started.
38, Dr. Mac.
No. Just a moment.
Okay.
Even though she has worked for the same traveling company for over 6 years, go back to the math. For 6 years at 32, the problem, no, in a depressive, in an anxiety disorder, ladies and gentlemen, I'm giving it away. This is when anxiety can start in adults. Note very carefully. So this is the time of onset. The 8 months is the acuity, is the exacerbation of the symptoms. That's when it started getting worse.
So then, Dr. Mac, Dr. Mac, are you saying that at 38, seeing that she started working, it says for over 6 years, and she could have been working with them?
No. She has had this disorder for 6 years. It got worse. Now, there is a difference between acuity and chronicity. Let me explain. This, she has been going through this problem for 6 years. So it started really at 32 years old. But for 6 years, she has been working in upper management, well-paying job, but she has had this worry for 6 years about losing her job. So we have a cognitive distortion here about reality, or distortion of reality, that she's worried about that. So in other words, she's worried about her job, but it got worse after June 8th. So for 8 months it took for this to be to the point where she is beginning to have the symptom severity. So the symptoms have worsened over the past 8 months. So within the 6-year span, within the past 8 months, symptoms have worsened. She can get this ruminating thoughts out of her mind. Now, if you understand the diagnosis, do someone have a DSM there? Anybody has a DSM on them?
Yes, Dr. Mark.
Go and look under the generalized categories for anxiety disorders and read the criteria. And I want you to look at the criteria here and see if it fits into that model. And then the horse will be drive the buggy. Go ahead, please. The 300.002. Generalized disorder. Early on.
Looking for it.
Generalized anxiety disorder under the anxiety disorders category.
I'm looking for it. A lot of anxiety disorder.
Look for generalized anxiety. I wish I had. I don't have a book in front of me to guide you, but just look for the diagnostic criteria.
I am going through. Okay, generalized. What you want to read now, Dr. Mark, the criteria?
Go ahead and read it. Make certain you're looking at looking at symptoms. Pull out the symptoms. Determine and see if it fits the model of the criteria in DSM-5. It should fit it. If it's not there, it's not it. Go ahead.
Okay.
Read it, please.
Excessive anxiety and worry.
Stop it right there. Do you sit in the vineyard?
Yes, Dr. Mark.
Continue.
Apprehensive expectation in bracket. Occurring more days than not for at least 6 months.
Stop it right there. Is there evidence in the vineyard?
Yes, Dr. Mark. She's been experiencing them for 8 months.
So it's now past chronicity. Continue.
Yes, about a number of events or activities such as work or school performance.
Stop it right there. Is there evidence of work performance in the vineyard?
Yes, Dr. Mark.
Yes, Dr. Mark.
The individual finds it difficult to control the worry.
Stop it right there. Is there any evidence of that?
Yes,
Dr. Mark.
Behaviorally, you have. I told you before. There is cognitive, emotional, and behavioral precursors to a disorder. There is cognitive elements in the vineyard, correct?
Yes, Dr.
She can't control it. Continue.
The individual finds, the anxiety and worry are associated with 3 or more of the following 6 symptoms.
Go ahead. 1.
Which at least, restlessness or feeling keyed up or on edge.
Is there any evidence in the vineyard?
Yes, Dr. Mark.
Continue.
Being easily fatigued.
Stop it right there. Is there any evidence in the vineyard?
Yes, Dr. Mark.
Yes, Dr. Mark.
Continue.
Difficulty concentrating or mind going blank.
Is there any evidence in the vineyard?
Most certainly.
Well, we have confirmed the diagnosis. We have now moved from hypothesis to fact. It's validated. We have a diagnosis. Close the book. Let's continue.
Okay, doctor.
Do you now understand what I'm trying to tell you?
Yes, Dr. Mark.
Yes, Dr. Mark.
Yes, Dr. Mark.
So these are precipitating factors. So the time of onset was from 6 years, 32 years old. So there is a moving from acuity to chronicity of symptoms, where it now morphed into a generalized anxiety disorder. Is it now clear? Have I studied with my brilliance?
Yes, Dr. Mark.
Yes, Dr. Mark.
Yes, Dr. Mark.
Yes, Dr. Mark.
And
Dr.
I'm
Mark,
still
can
trying to recover, Dr. Mark.
I beg your pardon? Mr. Barr, yes?
I'm just still trying to recover from that staggerness.
Okay.
Dr. Mark, could you clarify the question you asked earlier about whether it's severe or moderate?
What do you mean?
You were asking on the spectrum of mild to moderate to severe, where would you place this client? And I'd initially said severe, but I think most of the class said moderate.
Okay.
Based on her meeting all of those symptoms, what would you say? Where would you say she would be placed?
Well, if we were to look at a graph, this is why we will look at the axis 5, the DSM-5 categories. We look at a generalized anxiety disorder, axis 2, no personality disturbances, axis 3, medical disturbances, none. Axis 4, psychosocial stressors. She has what? She's divorced, and she has not poor, but she has problems with job performance. And the graph meaning that you're assigning, you're quantifying the symptoms of the stressors in terms of a numerical value. The GAF in the DSM-4 TR, I would give her about 60, 65, because there's a range. Below 40 is severe. You need to go into hospital. So severe is below 40, and so it ranges from 100 to 0. 100 means that you are fine, you have no problems, and I don't know if anybody was 100. Nobody has that. Even our good Lord, when he was on the cross, had a graph of 50. He was below. He was in pain, so his graph was low.
You mean that was analyzed, Dr. Mark?
Of course, I did.
Wow.
But what I'm saying is, yes.
Dr. Mark.
Yes, Mr. Barr.
That is because of us. That's
Mr. I didn't hear that.
It's because of us why Jesus had a graph of 50.
I think so. Well, no, he had not a graph of 50, Mr. Guy. If he didn't, then he would not be on the cross. He had a graph of below that. He had serious.
Because of
yes,
that.
That's right. He didn't want to die either. I think he had post-traumatic stress. He had an acute stress disorder, and he didn't want to die. But thank God he did, because we are saved by His grace, right?
True that. But Dr. Mark,
yes.
After the case, would you consider those 2 teenagers as part of the problem also, or
no? It's not implied. There's no evidence. No. What is implied is that those are identifying tags of the patient. Okay, so more demographic information, and so you find out in that case. We talked about cultural, in terms of the cultural formation, that this is a little woman who has been in a corporate culture, and she is not a personality difficulties, obviously, but she's primarily worried about anxiety and worried about that, and she started worrying about the anxiety from 32 years old. For 6 years she has had this problem untreated, until 8 months it starts getting worse. And so you'll find people that they'll come to you with the severity of symptoms after a certain amount of time. It gets so bad that they want to seek help and relief. So the symptoms seem to be moderate.
Moderate, okay.
Okay, so what I'm saying with moderate symptoms, I will more look at a gap of 50 to 60. 50, that's a DSM-TR. I'm not talking about DSM-5. Totally different. And a mild symptoms will be from 65 and up. But they no longer have that. But I still want to be able to use that for you to justify and understand the diagnosis. So the DSM-5 is that you will not have had access to, which is a personality. You will not have had any medical. You'll have had medical, but you'll mix them. So there is no evidence. The contextual factor is that she has had a very difficult job and she's a single mother and also she's dealing with job performance and worrying about it. All right, any other question before we wrap up with that? Duration is severe. He says hallucinate. Why asks Victor, why is she hallucinating? Where's the evidence? Is there any evidence of hallucination in the video? Anybody?
I don't recall seeing any, Dr. Mark.
Not seeing any, Dr. Mark.
Okay, well, I just saw this. He said having a physical emotion due to lack of performance, externalizing because she's not meeting good. But
maybe
why would it be? Ask him, why would it be depressive stress disorder? I don't know of any such diagnosis, but good try. Ask him, why would it be a depressive stress disorder, Mr. Victor?
Dr. Ma?
Yes.
The distressing and disabling symptoms would place this case as well as a neurotic type diagnosis.
Oh, I need to get a glass of wine.
Oh boy.
Yes.
Say that again, please. That one missed me.
Miss what?
What?
That I'm going to drink a glass of wine?
No, what Vanessa?
No, I was.
The Bible says you can drink wine for the stomach's sake, you know.
I was saying that the distressing and the disabling factors in this case would also make it a neurotic diagnosis.
That's very anything that has to do with distressing symptoms to the patient, where there is a disturbance in functioning, is neurotic. All right, any other questions before we move on to mental status exam? Mr. Nami, could you put up that clip, please, on the interview? I'm going to go up.
Just Dr. Matt?
Yes?
Just a comment to say that this is very helpful. I wish we had done lots more of these.
Well, yes, I know, but the time wasn't right for that yet.
Okay.
Everyone, could you please click on your YouTube video up? It's in the left corner when you move your mouse to the left.
Okay, clicking on the YouTube video. Click now, please.
Yes.
Okay.
When it's playing. Aye. Did somebody start playing? Did somebody start playing it?
Yes, we weren't supposed.
No, you were not supposed to play it yet. I just wanted
sorry.
To be on. Everybody seen it?
Yes.
Yes.
Okay, I'm gonna start it again. But I'll start it.
Yes, start it again, please.
Okay, Coach.
Okay. Watch.
Okay. Very good. Excellent.
Now you'll need to click back on the YouTube app to come back to normal.
YouTube app?
Yeah, click back on it again to the left to remove that from your screen.
I mean the little...
The red thing.
Okay.
The YouTube icon.
YouTube icon.
Okay. So
are you seeing yourself again?
Yes, we are seeing ourselves. Thank you.
Thanks.
Do you students on YouTube, do you now see why it's important to do a diagnostic assessment, an assessment rather?
Yes, Dr. Yes, Dr. Mark.
So it now leaves us to go into the MS mental status exam. It's 10 o'clock by my watch, so what we'll do is go through this, and then I think we will continue with the DSM. I'm going to go through the number of categories in the DSM on Monday, God willing. I'm going to look at the DSM, what has been in it, what has been taken out, and then I'm going to go into case conceptualization. I want you to look at, there are 2 videos that I asked Mr. Some have been put online, but one primarily is behavior disorders of children. And I want you to look also, there's a video on the role of the psychological and the physical interactions on annetberg.org. We can't watch it on this forum, so please go to it privately and watch it for Monday's class. Do I have your word? Hello? Hello?
Yes, Dr. Mark.
What's the name of the Annenberg piece, Dr. Mark?
annetberglearner.org.
Right, but what is the title you're supposed to be looking for?
Looking at behavior disorders of children.
Okay.
And looking at the role of the psychological and the physical. It's more integrated, an integrative model.
But in Annenberg, though, it gives you a headings, just like abnormal behavior or personality disorder. Which one would we be looking for?
There is a clip on video on demand that talks about behavior disorders of children, and there is one video that talks about I think I sent him out, so he'd probably have to put it on the platform for your viewing. Also, last couple months ago, I did a comprehensive viewing of a lecture on case conceptualization in Child Adult. I wanted to also go, he put that clip up and watch it, because it does have some things about case conceptualization that you can find useful. Because we're going to have a short class with the presentation, I'm going to have you watch it. And because I did a great, it's with children, but it goes across adults. So I wanted to watch that video. It's called. Yes.
Go ahead.
Go ahead. No. Finish your sentence.
Something just crossed my mind. If we're going to have a class on Wednesday, I'm sorry, on Monday, and then we're going to have another one on Wednesday, it's going to kind of cut down on the time that we have to prepare for our posting and things.
Oh well, yeah, but I don't know how we can manage that.
And we really haven't heard from the majority of the students as it relates to Wednesday or Saturday. Just myself, Vanessa.
I heard it said Wednesday. That's what I heard.
Mr. Barr and Eileen.
Well, I think. Okay, can we push it then to Thursday or Friday? On Friday.
Well, it depends on closure.
No. What I'm saying is not the. I'm talking about the postings, not the class.
Oh.
I think I had a glass of wine a while ago, so I'm feeling a little merry.
A little merry. Well, Thursday will work for me. I don't know about anybody else.
Students, come on and let's know.
Thursday is fine for me.
If we have the class, if we have, it's pro quid quo. If we have the class, then we must have that class. Mr. Nam has been gracious to help assist. We must have that class. We have to make up.
So if we have the class, we can do the posting on Thursday and respond on Friday.
That's correct.
Okay.
That's fine with me, Dr.
That sounds like it can work.
Very good. All right. Let's
Wednesday it is.
Okay. So let's look then at the mental status exam. This is, I'm going to be looking at this. An excellent capturing of what I'm going to be giving you with Lisa. Now, if you notice Lisa, let me comment. Lisa had what is known as a drug-induced psychotic reaction. A drug-induced that's how psychosis brings about. There is a disconnection in reality. There is perceptual disturbances I was talking about, and there is thought. There's illogical thought and sequencing of thinking. Now, what is the mental status exam known as the MSE? It is a systematic appraisal of a person's general psychiatric functioning. The person's general psychiatric functioning in the form of 1, appearance. Very important. Appearance. 2, behavior or demeanor. Person's behavior or demeanor. 3, state of mental functioning or mental state. 4, emotional functioning. And 5, reality testing. And 5, reality testing. In other words, is there psychosis versus psychotic, neurotic thinking? The MSE for short is a major component of diagnosis and assessment. It's a major component of diagnosis and assessment of a patient or client. It is, the MSE is more a assessment of observation. It's an assessment of reporting in a narrative form. Observation. It's reporting in narrative form. It is providing a diagnostic case formulation of a group of symptoms, providing a diagnostic case formulation of a group of symptoms or a cluster of symptoms. It is based upon the what, why, and when of diagnosis. I won't elaborate now. I elaborate further later on. When you watch that video, that lecture I did, watch up to 53 minutes of it, and then that will help. The other part is irrelevant to the course. But watch up to the 53 minutes, primarily the case conceptualization. If you don't watch anything else, watch that. I sent it to Mr. Nyame, or it's on the YouTube. You can Google it, but I sent it to him for you to put on the web, but on the platform. But watch up to the first. Beg your pardon?
I've added it already, Doctor.
Oh, great! It's there. Let's continue. So, so the mental status exam looks primarily at the patient's mental state and cognitive capacity. It is based upon reality testing, awareness of the environment. It helps the clinician to determine functionality of the person. Functionality of the person. It is more related to the developmental level of the person. Is this behavior typical of this person at this age level? The MSc also assess, as she said in the video, risk or suicide assessment. In the case of Lisa's drug use, it's risk for drugs. But in the case of a psychiatric set of symptoms, you're looking at suicidal / homicidal ideations or intent. Suicidal / homicidal ideations. You must assess risk to self and others. If there is risk, there is a level of severity of symptoms below 40 in quantifying that, and the person needs to be hospitalized to protect themselves and others. So this matter of suicidal ideation is linked to what is known as the Tarasov decision. I just mentioned that briefly. Tarasov, T-A-R-A-S-O-F-F. Tarasov happened a couple years ago in the States, where a psychologist failed to notify. The patient mentioned that he was going to hurt somebody, and the psychologist failed to notify the other person that he was in imminent danger, and the person was killed. And so it created called the Tarasov. It's a very big case. And so it's now the Bible of mental health that you must ask about ideations, risk. Unmute your mics. Is it clear?
Yes, Dr. Mark.
Okay, so the mental status exam has a number of domains. Let's go through them very quickly. I hope I can finish in a little bit. But as it says, appearance is important. It provides clues to the person's ability to take care of themselves, perform activities of daily living. Can they take care of themselves? So you can have atypicality in appearance. A man who comes in a suit and tie with a banana peel on their heads, that's atypical behavior. That's called incongruence of behaviors. Men who dress in jacket and tie don't come with a banana peel on their heads. That person may be psychotic. So appearance. Look at clothing, grooming, hygiene. Important in appearance. B is behavior, as you saw in the video. Behavior. Behavior. These are the persons, as we talked about. Remember we talked about the cultural formation? Remember we talked about that? You remember we talked about that?
Yes, Dr. Mark.
Yes, Dr. Mark.
We talked about cultural concepts of distress. Behaviors are what the manifestation of behaviors in the interview that demonstrates abnormality versus a normal function within the accepted boundaries of culture. So watch non-verbal communication. Shifting eyes may mean, in this context, in Jamaica, Guyana, Canada, United States, can mean a lot of things depending on who's in front of you. If it's an ethnic group, then it may mean something else. So wringing of hands in an interview, biting the nails can signify anxiety. Tears can signify depression, pain. So the behaviors reveal the extent and the inner experience of the person's emotions, attitude, and belief systems. Is it clear? Can I continue?
Yes, Dr. Ma.
Okay. So, under behavior, body language and gestures, posture, slumped in the chair suggests a nonchalance about things. Giving up, depressed. Eye contact. Do they make eye contact? In Caribbean culture, North American culture, poor eye contact means that the person is unable to, there is lack of poor self-esteem. In other cultures, it's not. Is the person engaging in you? Are they reticent in speech? Do they talk to you? So you look at level of arousal. Are they calm? Are they agitated? Are they mute? Is there anxious or aggressive behavior in the assessment process? Be careful about danger to self. So you need to be concerned about that. If the person is aggressive, especially, you may want to have sit near where you can exit out the door if they attack you. On the behavior, psychomotor activity. Is there hyperactivity in children? Note that in the DSM. Can an ADHD child sit still for you to talk to them? Those are psychomotor activities and behavior. Hypoactivity suggests that the person is so depressed they're not moving. Yes. What is your name? My name is... So there is no sense of, there is almost like emotional inertia within them. Difference. Any unusual features of behaviors like tremors, repetitive or involuntary movements are important. We are looking probably at an organic disorder, Parkinson's, Huntington's chorea. All those are signs of psychomotor activity or unusual features. Unmute your mics. Any questions?
None for me, Dr. Mark.
None for me as well, Dr. Mark.
Likewise, Dr. Mark.
Okay.
None for me.
Mood and affect is another major heading of the mini mental status exam. Mood and affect. And this is a very important part of the assessment. It determines the state of the person's severity of symptoms, their coping mechanisms, their idioms of distress, the cultural formation, the context and the cultural is there a culture-bound syndrome? So mood and affect are integrally linked. Mood and affect are integrally linked. You can't do without the other. In fact, affect determines the manifestation of mood. So affect refers to the immediate expression of emotion, usually in the facial area. So affect can be seen as normal, called euthymia or euthymic, E-U-T-H-Y-M-I-C, normal. Affect can be known as constricted, constriction, and constriction normally means in range and quality of the affect. Affect can be flat, no response, no emotion in a brain damaged person or person with schizophrenia that is showing negative symptoms. Normally you see flattened affect. Affect can be affect can also be linked to lability of mood, varying ranges of emotion, called lability. Affect can also be expansive, as in mania, hypo or hypermania. Affect also deals with appropriateness. Laughing at sad things are incongruous to mood. So a person laughing at somebody who has died is incongruous. Is it appropriate in terms of the affect, in terms of responses, or inappropriate? Affect is stable. Is it stable, or as I talked about labile mood? Stable means that the range is stable, normal, stable. So mood then is defined as, could people mute their mics? I'm hearing some feedback, please. Thank you. Refers to emotional experience over a prolonged period of time. So mood is more seen in the manifestation of internal experience or the emotions. So let's go through them quickly. Happiness. Do you have depressed mood, which means sad? Is it elevated, which means that the person is manic on the other spectrum of sadness? They are happy, and they're always happy. Is mood irritable, as in the case of the first lady who had irritable mood? Is the person explosive in their behavior? Are they angry, irritable, or calm? Unmute your mics. Any questions?
None from me, Dr. Mark.
Okay. Speech. Speech. Major categories of the MSc. And this is pretty straightforward. So, speech. And Mr. Nami, in the interim, there's another one, I think it's another male. Can we, I think we try to play that tonight to get a sense of from a different perspective of a male. Okay, that would be the other one. Okay, let me try and get that. Yes, Barry, speech, and I will, excuse me, speech. Speech is an articulation of one's thoughts and the nature of how one experiences reality. It is divided into speech rate, volume, intonation. I'll explain those. Prosody or quality. Speech rate. Is it rapid, pressured, reduced? Rapid, pressured speech is a person who is going through manic symptoms. Is it normally? Normal means that the person is in touch. So rapid pressured speech is in tune with the mood and the cognitions. So a person who says that they have racing thoughts can be either manic or they can be anxious. Volume, is it loud, normal, or soft? The speech. Intonation, is it monotonous? Is it will be somebody who has schizophrenia and their thought patterns are confused, or somebody who has brain damage. Quality of speech. Is the speech goal-directed? Is it illogical? Is it making sense? Another one I want to add is ease of conversation. Is the person's speech patterns clear to understand? Clearness means that the person's brain processes are intact and functioning. So a person who has a stroke may be dysarthric. They may have dysphagia or difficulty speaking. So look for that. Even a child with a communication disorder, you're looking for how is this person articulating words and sounds. Very important. Is it up now, Mr. Nami? Is it up? Yes, it is. People have to go to their YouTube now if they're ready. Oh, okay. Let's continue. We haven't done with the mental study, but I think people are getting the idea of what it entails. But go ahead. So are we to mute? Go on. No, just go to your YouTube app again, the YouTube icon. Yes. On the left. On it. Please, everyone. Could people click, please? I'm gonna start in 1, 2, 3. Okay.
Okay. Now click back on the video icon to get back to your gorgeous faces.
All right. So, ladies and gentlemen, are you not understanding the DSM? I mean, did I say the DSM? I mean the MSc.
Yes, Dr. Mark.
Yes, all right.
Yes, Dr. Mark.
I still have some more to go through.
Dr. Mark.
It's 11 o'clock by my watch.
I'm wilting and falling asleep.
Very tired, so I am tired myself. So I think we need to conclude right now, and I think we got a lot in this evening.
I believe so, Dr. Mark.
And so I'll try to wrap up as quickly as I can with the MSc. I may send Mr. Nyamis one or two more clips of this because I think it's important. It gives an idea of the MSc in action. And I will be going through again the categories of the DSM and sort of look at the changes and try to fit in the case conceptualization. I am not certain again if I can finish, but I'm glad we have Wednesday to wrap up finally everything.
Yes,
are there any questions, ladies and gentlemen?
I'm from me, Dr. Mark.
None from me, Dr. Mark.
I am contemplating if we should, before we go, if I should put that while I'm talking about case conceptualization, if I should show snippets of the lecture on the classroom platform. Will that be helpful to explain?
That would be helpful, Dr. Mark.
Okay, so Mr. Nyame, could you put that up, prepare to there is a video, I mean a lecture I did a couple of months ago on the child and adolescent therapy, the case conceptualization, and the Child Care Act.
It's up there already in the morning.
Okay, so we will defer to it, and at some point we'll stop and ask questions. All right.
That's the one you told us too much about 53 minutes of it, Dr. Mark.
Yes, but we decided that you will not watch, we'll watch it in class together.
Oh, okay, okay.
So I wanted to look at the behavior disorders of children and the other one for the adults for Monday, please.
That's the one on Annenberg Learner?
Yes, and I think there's also a clip on case conceptualization.
Okay.
So you can watch, it's a short clip, so you can watch that by YouTube.
Okay, Dr. Mark.
Okay, any questions? I think people are falling asleep on me.
Yeah, but before we go, will we be getting a sample of a complete case that is completely written up? Or we will have to work that out by ourselves?
No. The aim is in this class is for you to be able to come up with the gems yourself. My goal is to guide you in give you practice, which we'll do for the next 2 days. Monday and Wednesday, give you practice. That when you're going to do your the take-home exam, you'll be able to you will know what to do with the cases.
Okay.
All right. So it's not to, yeah. Okay. Any other question? If not, I wish you all the best. Thank you very much for making the commitment to come to the class. And at this time, we'd like to ask someone to close in prayer. We didn't open in prayer, and that was remiss of us to do that, but we will honor God by closing in prayer at this time. Can someone pray? I see Mr. Gaia's face online. Can he pray if he hears me? Is he able to do that? Pray. Okay.
Yeah. Lord, we give you thanks for life. We thank you, Lord, for allowing us to be at this session. We ask that you just help us as students so that we'll be able to not only understand but to apply all that you have learned. Father, we ask that you continue to bless our lecturer and just help us to do exceptionally well in this course. In Jesus' name. Amen.
Amen. Amen. Okay. Thanks, Dr. Mark.
Yes.
Enjoy the rest of the weekend.
You too. I've not heard from Miss Spencer. Is she listening or hearing?
I'm not sure, but she may be hearing.
She's there. She spoke earlier, Dr. Ma.
I didn't recognize the voice. I'm sorry.
Yeah, she was part of the discussion earlier.
Okay, I didn't. I must have had a lapse of diminished capacity.